Hello, everyone, and welcome to the webinar. We've got about 25 people online at the moment and just over 50 registered. So some more people will join us, I think, as we go along, but it's worth getting started now to help us keep the time. So thanks very much for joining the webinar today. I was going to give a very brief introduction and then hand over to Joe Morrison, who is going to be moderating the panel today, to introduce the panel and then to go through the presentations. Just a quick bit of background. This is a third webinar in a webinar series, a new PLA webinar series we started that started at the end of last year. The first webinar really was a bit of a scoping exercise looking at where we've reached in terms of PLA, what the state of the art was, and potentially the new ground we wanted to break with PLA going forward. And then in March, our last webinar was addressing one of the big questions facing PLA, which is how to get it to scale. And we heard from our partners and colleagues in Ectut, who shared their amazing success in scaling up PLA in India. And also we heard from the WCF team, Women and Children First team, talking a little bit about other ways of scaling up PLA beyond community health worker structures. But today, the focus is going to be on adapting PLA beyond maternal and newborn health. And we've got a fantastic group of speakers speaking today. Just to let you know that we're intending to continue these webinars on a quarterly basis. The next one in September and the final one this year in December. We've got some good ideas already lined up for potential future webinars, so we'll keep you posted on how those progress. It's great to see so many friendly faces and new people joining the webinar, and hopefully we'll have an interesting discussion and hear some fantastic presentations. Joe Morrison, Dr. Joe Morrison from UCL will be moderating the panel today and taking us a little bit through basically what it takes to adapt PLA, what it means to adapt PLA, and some of the considerations you need to think about when adapting PLA beyond maternal and newborn health, where it clearly has a very strong evidence base and a strong track record. Professor Kishu Azad from Badas PCP will be taking us through the adaptations that she and her team went through to adapt PLA to diabetes mellitus prevention in Bangladesh. And then Anna Main Sondal from Women and Children First will talk a little bit about adapting PLA for family planning uptake in Ethiopia, an ongoing project in Ethiopia. Throughout the presentation, we'd love you to interact with us. The two main ways to do this are one through the Q&A box. If you have any questions for the panelists, please put them there. At the end of the presentations, Joe will be fielding those questions and pushing them to the panelists for some answers. But also we want to hear not just your questions, but also any experiences you have that resonate with what the panel are talking about, or any ideas about things that you're doing about adapting PLA beyond maternal and newborn health that you think would be interesting for the rest of the group to understand and learn from. There's also the chat box. Please use this to interact with each other. You should be able to interact directly with people, or also to the whole participant group. Also, please put any technical issues in there, and I'll try to respond to them if you're having trouble seeing or hearing anything. Final thing is just to let you know that this presentation is being recorded and will be going on the website after this presentation. So please keep that in mind if you're planning to interact in some way. The last thing to say is that this webinar series fits within a community of practice that we're building around PLA. If you visit the website address there, you can join the community of practice. And through that, you can get news about PLA, so breaking news of new projects starting, new research studies published, and new ideas, as well as the webinar series. Obviously, you can see the previous webinars have all been recorded and are now stored there, and all the future ones will also be. There's a forum, we're still working on the forum to enable the participants of the community practice to engage with each other. There's also a library of published studies, films, and reports on PLA. So there's a lot of information there to dip into if you're interested. We're really hoping for the community of practice to be something for everyone. So we're very keen to get your inputs, get your advice, get your ideas about how to expand it and continue being a useful resource for people working around PLA. That's all I was going to say. So I was going to hand over now, unless there are any immediate questions. I'm just checking the chat. I'm going to hand it over to Joe Morrison, who will take us through the next piece and introduce the panelists and introduce us to the concept that we're going through today.
Hi everyone, it's lovely to virtually see you all. Of course, I can't actually see you all, but I know you're there, which is lovely. Just going to share my screen with you. So I will be, my name's Jo Morrison, for those who don't know me. I work at the UCL Institute for Global Health. And I've been working in PLA for around about 20 years. I love working in participatory ways, and I hope I can kind of bring some of my experience. I have done most of my work in South Asia, particularly in Nepal and Bangladesh, and worked very closely with Professor Kishu, who will be talking in a minute. So one thing is I can't really see the chat. So if you've got a technical issue and I'm not responding, just either write in the chat and Mikey will let me know, or just let me know yourselves, unmute yourselves. So I thought just to kind of focus us to the topic, we could just have a quick explanation of what PLA is. So it's a collection of approaches and methods that enables people with an experience of an issue or of a context. So you might be a mother, or you might just live in a community where there is newborn health problems. It enables people with that experience to share it, to analyze their situation, analyze why newborn babies are dying, and then plan and take action collaboratively for social change. So it's not looking at sort of individual behavior change, it's looking at how to change the society, how to make it better, how to address those problems together. So I work as a researcher, or you might have an NGO worker who is like an outsider. So they don't have the direct experience that stakeholders have. And as outsiders, we need to facilitate and not dominate. We need to acknowledge our position of ignorance. And we need to, our role is really to help guide people through this process of analysis and planning. So I thought I'd put up two pictures of two different PLA cycles, because they're essentially the same. So WCF and also my work at UCL, we have systematized PLA into this phased cycle, which I'm sure a lot of people are familiar with. So on the left-hand side, that's a diagram from the very first trial of women's groups for maternal and newborn health, where groups identified problems and then worked together as a group to think about how to address those problems, and then implemented them and evaluated them. So an example of a problem could be, as I say, a social problem. So it could be in terms of women's gender norms preventing women from accessing antenatal care. Or it could be an actual medical problem, for example, postpartum hemorrhage. And then on the right-hand side of my screen, we have the PLA cycle that we used in Bangladesh, which Kishu is going to talk to you about. So you can see it's essentially the same, but in that problem identification phase, we've sort of focused on some of the key risk factors for diabetes. And then some of, obviously, the strategies align with the problems, and so it's in that way it's different, but the cycle itself is the same. So as Mikey mentioned, the maternal and newborn health kind of evidence base for PLA has been kind of established by a systematic review and meta-analysis that was published in 2013. And that was looking at 7 cluster randomized control trials, and found that when compared with areas that weren't running PLA, there were huge gains in maternal and newborn health. You can find lots of other evidence in the WCF virtual library. But I also wanted to draw your attention to the second paper, which provides us some evidence that PLA works in other areas, which Kishu is going to talk to you about. So our paper was published in 2019, and we used PLA to look at type 2 diabetes in rural Bangladesh. And we found that compared with areas that weren't having PLA, the diabetes burden was reduced by 64%. So it had a huge impact there. Obviously, there is a lot of other evidence, which I'm not talking you through, and PLA has been applied to lots and lots of different topics by us, WCF, and other organizations, and there are some here. We're just working with Keshu on a trial of a pilot of PLA for unintentional childhood injury, which is hopefully going to push the evidence base as well. But also PLA has been used for antimicrobial resistance, gender-based violence. HIV also has taken a lot of participatory approaches. So you can find resources on that in that virtual library, which WCF has. So one of the reasons that it's kind of feasible to apply PLA to these diverse topics is because of the nature of PLA. It is flexible, so it can be flexible to the context and to the issue. So because it's participant-led, we as outsiders may kind of present an issue and want to interact with the community about an issue. But if they feel that's not the key issue, then of course the process can be changed. And so the implementation of PLA is planned with stakeholders. And we often interact with those who know the context. In fact, we always interact with those who know the context before planning an intervention. And one of the ways that we sort of know our context is through doing that formative research. And so that can be sort of, qualitative, in-depth formative research, or it can be really sort of like scoping kind of research, trying to find out sort of how the problem is defined, cultural definitions, contextual barriers and enablers, and also getting an understanding of local taboos and local issues, so that we can train facilitators to kind of anticipate some issues. We can also use some of the real life stories in our stories and our games, which we often use in the participatory process. Also, just kind of getting a lay of the land, knowing who is working on this issue in the area, what has been done, what services are available. That type of formative research is also really important. So it's useful also to make a theory of change. So that helps you map out sort of how you think the intervention might work. And although the theory base for PLA is developing, it's nice to make program theories which are specific to the issue and the context that you're in. And that can help you identify potential barriers which might stop participatory processes from working, but also stop the intervention from being effective. And then you can try and plan ways to protect the intervention, or ways to address those barriers before you start the intervention. So my last slide is really just to put up some questions which you might want to answer before you consider whether to do a PLA intervention. You want to see how much support there is for taking a participatory approach within your own organization, but also among different stakeholders there. Are people convinced by the value of a participatory approach? You need to think about to what extent people can participate, and they might not be interested to participate. They might not want to. There might be barriers to participation. People might not have enough time and money and resources to put towards participation. So once you've kind of answered that question, you might want to think about how to support stakeholders to participate and to work together for change. you know, in societies where there are a lot of hierarchies, or places where there are severely marginalized people, huge inequalities between different groups, you might need to do specific activities to try and engage different stakeholders. But also there are sort of low-level type of skills development that you can do. For example, like this picture is of a facilitator, Awantika, who is teaching Mina how to use a recorder, because she's going to record some data for that problem identification phase. And she's illiterate, and you know, and we did a verbal consent process, a pictorial consent process, sorry, to enable her to and taught her how to use a recorder to enable her to do that. Also thinking about social and political acceptability of an issue. For example, you know, diabetes is not something which is very controversial or very taboo. And so it's quite easy to talk about it in community groups and community settings, but that might not be the case for your issue. Thinking about what other frameworks have been successful, you know, review the evidence, what has worked, what can PLA or taking participatory approach add to the frameworks that are already there. And then think about what services and networks already exist, with who you can partner with, who might be interested, who's a resource, and then is there a need really to, if services are not good enough, and there are you know, serious systems issues, then perhaps it's difficult for communities to interact with governance structures, and there might need to be some brokerage from facilitators, outsiders, and communities to help that forward. So I'm not going to say any more here, but those are just a few things to consider. So maybe I could hand over now to Kishu, who's going to talk to us about the experience of adapting PLA for diabetes in Bangladesh.
Yeah, my share screen করে দাও. Just 2 minutes. I'm not familiar with this computer.
No problem.
So, share screen. No, but I have to open it. My key. You switch. Somebody is already sharing the screen. So can that person switch it off, please? Right. And what is this?
Like you're coming.
There's something. What is this? Now. Yeah, that's better.
That's great. We can see your slides now, Kishu.
Am I unmuted? Yeah, and can you hear me?
Yes, we can hear you.
Can you hear me? Am I? Okay, fine. So what I'm going to talk about is adapting PLA, and we actually worked in maternal neonatal health, and then recently we adapted the PLA.
Could you possibly put the slideshow view on your screen so that we can see the full screen?
You can see my screen?
We can see your screen, but we can see you know, the slideshow view. It's the fourth icon along at the bottom. That means that the whole screen is taken up.
Oh. 1 minute. Where? Huh? Can you see now?
Yeah, there's, do you see at the very bottom of the PowerPoint, it says notes. Do you see that? Yeah? So if you go along 4 icons, there's like a kind of like a Sort of like a robot looking thing.
Which one?
If you, can you see the scale, Kishu, where there's the minus and the plus? It's just to the left of that scale.
Can you see now?
Oh, no, it's gone.
So
You can't see anything now.
এটা না শেয়ার স্ক্রিন করো না ভাই। না না চলছে না। That is not screen share, ওটা তো আমাকে দেখতে পাচ্ছে। শেয়ার স্ক্রিন মানে এই জিনিসটাকে শেয়ার করতে। এই ফারুককে ডাকো।
এটা মিনিমাইজ করতে হবে। আমি মিনিমাইজ করে দিয়ে আপনি ডাউন করে দিচ্ছি।
You want to share your screen again, Kishu?
Yeah. স্ক্রিনটা শেয়ার করো না।
এই যে স্ক্রিন শেয়ার আছে।
কোথায় শেয়ার স্ক্রিন? স্টেশন তো নিচে থাকে।
শুনলেন আবার দেখতে পাচ্ছি না?
না এখন তো স্ক্রিনই শেয়ার করিনি তো কি দেখবে তোরা কি?
Can you see the share screen button? Can you see the share screen button, Kishu?
Can you see now?
No, I can't see it. If you'd like to, you can email it to me and I can share it.
Okay. Shall I email it? Can Annie start? Or will it screw up the presentations?
No, I think that could work. Annie, would that be okay with you?
Yeah, absolutely. I can present my piece and then we can sort this out in the background. No problem.
Okay, that sounds great.
Okay, so I'll just share my screen. Are you able to see the screen now?
Yes.
So Kishu, if you could just mute yourself, then I'll start my presentation. Thank you. So yes, so I'll take you through today through the process we went through at Women and Children First in order to adapt PLA beyond maternal newborn health and adapt it to address family planning and sexual and reproductive health. I'm just going to turn on my video as well. Great. So the project that I'll be covering today is a pilot project with MSI Reproductive Choices Ethiopia, also known as MSIE, in which we are piloting an adapted PLA model for family planning and sexual and reproductive health. We are piloting this model in 60 groups across the Amhara region, covering a population of about 30,000. And MSIE identified the need for a tailored approach to really expand their outreach work in the hope that it could be effective at generating more demand for family planning and SRH services. And as Jo already mentioned in her presentation, the local context and issues are really important to kind of the adaptation process. And so I want to quickly focus on two important things about this particular local context in which the project is being implemented currently, which really influenced the considerations we had to make when adapting the approach. So first, the role of the PLA group facilitators who take the community of concern, the group, through this cycle of meeting, here is taken on by the existing MSIE family planning promoters. So it's private sector family planning promoters who are the facilitators. And just to note, their remuneration is based on the number of people successfully referred for an SRH service. And also, despite the availability of kind of comprehensive and accessible services in Ethiopia, uptake of contraceptives and SRH services remains low, particularly among the more disadvantaged and harder to reach groups, which includes unmarried women and adolescent girls. And so Joe already briefly touched upon the traditional cycle for maternal newborn health and how it's also being adapted for diabetes. But I'd like to share a few more detailed characteristics with you that are important in understanding the adaptation, which I'll present to you shortly. So as Joe mentioned, the PLA approach activates communities to design local solutions to overcome the problems they face, and community members form concern groups. And usually a trained local facilitator will guide the groups through structured meetings in a 4-phase action cycle. And in this action cycle, there are separate meetings. And this cycle takes groups about 12 to 18 months to complete. So within 12 to 18 months, they go through a cycle of meetings where they go through those 4 different phases. So the identification of problems, the identification of solutions, the implementation of the solutions, and the evaluations of the solutions. The PLA methodology has also already been applied successfully by Women and Children First to improve family planning uptake. So for example, in Malawi, it significantly increased the contraceptive prevalence rate, as well as comprehensive knowledge on family planning, and also changed attitudes. And similarly in Ethiopia, PLA groups focusing on RMNCH changed attitudes towards family planning, contributed to reduction of unplanned pregnancies, and also increased the contraceptive prevalence rate. So with this in mind, our aims for the adaptation were really to use the principles of PLA to build on the fact that traditional PLA improves uptake of family planning, to ensure that all women, including unmarried women and adolescent girls, who are less likely to use sexual and reproductive services due to a mix of social, cultural, and financial barriers, would also be able to join, and to ensure that this particular cadre of staff, the MSIE family planning promoters, would be able to use this adaptation. And so I'll just run through now the considerations we took and the adaptations we made to the approach to achieve these aims. So first of all, we needed to consider how we could ensure that family planning and SRH would become more prominent in the discussions. And although at the same time we didn't also want to hinder certain women, particularly those unmarried women and adolescent girls, to join groups if the main theme was family planning and SRH, especially in a setting where discussing their sexual and reproductive health needs is not common. And so we needed to consider, how do we make family planning and SRH more prominent in these discussions without limiting certain people to join groups? And as a result, we decided to frame the groups with a broader focus, namely a well-being focus, supporting women to thrive in their communities. And with the anticipation that this broader focus on women's well-being would also encourage unmarried women and adolescent girls to attend, and would ensure they'd be more likely to engage. And so with this well-being focus, we of course still needed to focus on those issues where the key determinant of the women's well-being is family planning and SRH related. We also needed to consider how to ensure that women joining later on in the groups would still learn about family planning and SRH. In the traditional PLA maternal newborn health cycle, family planning and SRH kind of would be discussed as part of the initial health problems meeting in phase 1, but not so much after. And so again, we needed to make sure that family planning and SRH is discussed at every meeting. And as a result, we decided to make an adaptation to the cycle. And this is where I'll kind of feed back into the old cycle, because as mentioned earlier, the traditional cycle goes through the 4-phase action cycle in roughly 12 to 18 months. But the adaptation we made now is that each group goes through the entire 4-phase cycle in just one meeting. In each meeting, they go through the 4-phase cycle. And as a result, this would allow each meeting to focus on a separate problem at one time, and would mean that family planning and SRH would be discussed at every meeting throughout the whole entire project. So I'll just kind of go into that in a bit more detail as an illustration. So illustrated here is the cycle of meeting in this adaptation. And it looks very similar to the traditional cycle, but you can note that each problem meeting has the 4-phase cycle within it. And each problem meeting consists of 9 steps in which they go through the 4 phases of the traditional PLA MNH cycle. So for example, in step 2, they discuss the problem and the signs and symptoms of the problem. In step 4 and 6, they discuss what causes this problem, what practices can help to prevent the problem from arising or manage it if it has already arisen. In step 8, they discuss the barriers to performing these practices. And in step 9, they discuss what locally feasible solutions can help to overcome these problems and the barriers. And discussion throughout these steps will be stimulated by stories and picture cards illustrating common family planning and SRH problems, prevention and management behaviors and barriers. And to come on to the third consideration we needed to take was, how do we ensure that solutions would be started earlier to shorten the lead-in time for uptake of contraception? This is also in relation to the MSIE family planning and promoters and responding to that, because as mentioned earlier, the remuneration is based on the number of people they successfully refer for an SRH service. And we needed to acknowledge that this is how they work and needed to include that in this adaptations. So with groups starting their solutions earlier, enabling them to access the services more easily or more quickly, the promoters then also achieve their targets more efficiently. And then with this consideration, the adaptation that we decided to make also relates to the previous adaptation, and that's about each group going through the entire 4-phase cycle in each meeting. This doesn't only allow each meeting to focus on one separate problem, but also it allows the groups to start implementing their solutions earlier. Because with this adaptation, the implementation of solutions is likely to start within 2 to 3 months of establishing the group, rather than the usual 7 months in the traditional cycle. And then finally, the final consideration we needed to consider, that is this, again, the specific cadre of staff that we be working with this adaptation. And that's the MSIE family planning promoters who are within the private sector. And the 2 previously mentioned adaptations really also address this final consideration, because first of all, focusing each meeting on a separate problem is a structure that these promoters are more familiar with. It's more curriculum based and is more familiar to their role of already sensitizing communities. And the second, which is that each group goes through the 4-phase cycle in each meeting and starts solutions earlier, is also responding to the way that the MSIE promoters work, which is that their remuneration again is based on the amount of referrals. And so that's a brief outline of how we adapted this approach to really fit within the local context and address family planning in SRH. And we think this adaptation has real potential. It offers a structure that might be applicable to other issues. It can provide a buffer for people moving in and out of groups. The cycle length can be adapted, and problems that can be addressed can be changed depending on the need of the communities, really responding again to that local context and where that formative piece of work that Joe mentioned is really crucial. And so thank you. I'll be happy to now hand over to Joe and Kishu for the next presentation and answer any questions in the Q&A.
Thank you very much, Annie. Yeah, really interesting to see those adaptations and to try, and it's often a question that we're asked is kind of how long does it take, and is there any way that, you know, to kind of speed up that process to make that change. So it's interesting to hear your experience. Kishu, I've got your presentation. Should I share it? And then you can just let me know when I need to go forward on a slide. Okay.
Right.
Can you see that? Okay.
Yep. Fantastic. Thank you, Joe.
No problem.
What I'm going to talk about is how we adapted the PLA from maternal neonatal health to diabetes. Next, can we go next? Right. So first we did community mobilization with women's groups to improve maternal and neonatal health, and that was quite a while ago. Next, please. I think this will take a long time. So what exactly is community mobilization? It's a capacity building process through which community members, groups, organizations plan, carry out, and evaluate activities on a participatory and sustained basis to improve their health and other conditions, either on their own initiative or stimulated by others. Next. So, but why do we go for community mobilizations? It's because interventions which empower groups are more effective and scalable than individually targeted health education programs. And this was proved in a trial, next, which showed that there was no impact of direct health education, so one-to-one, on infant care outcomes. Next. So you have all seen this cycle, which can be adapted to the various situations. We used it to address maternal and neonatal health problems, and then we moved on to NCD, particularly diabetes. Next, please. So this is the cycle in detail. So firstly, you identify and prioritize problems. For example, in MNH, we identified, for example, bleeding during after delivery. And then the community discussed ways to address the problem. For example, they would take the patient to the hospital, so get hold of a van to carry the patient to the hospital. And then in the end, they assess the impact. Next. So we had paid facilitators who used tools which we designed, that is picture cards, manuals, and flip charts to facilitate the discussion. Next. And the meetings were very participatory. They enjoyed playing games using picture cards. Next. And this is the facilitator leading a discussion on one of the problems. Next. And loads of people asked us, how do the groups work? So it was an accumulation of factors. I mean, there was the use of safe delivery kits, which reduce neonatal mortality, then hand washing, use of bed nets where there was malaria, breastfeeding, etc. And I think most importantly, they accumulated emergency funds which they could use in time of need. Next. And these are some pictures from our community mobilization. You can see a lady talking to quite a big crowd, and this was a community meeting where they shared their experience and shared what they were going to do. And in the end, you can see that there is a van. This was one of the earlier strategies. Now vans are available everywhere, so this has been dropped from the strategy. Next. So you can see it is an ongoing process. It's not a stagnant process that if you have one strategy, you can't change it. Now then we adapt. I mean, the MNH trial showed that there was a more than 30% reduction in neonatal mortality. And so we moved on to addressing diabetes and in future other non-communicable diseases. And we did the Bangladesh D-Magic trial. So it was diabetes mellitus, action through groups, or information for better control. Information for better control was through mobile, so we won't touch on that. It's diabetes mellitus action through groups that I will be referring to. Next. So we all know that type 2 diabetes is a lifestyle disease. So basically, if you eat too much, if you are obese, if you don't exercise, then you are more likely to get this condition. And the people in Bangladesh are are on the whole very conservative and religious. So they put it down to getting diabetes to the will of Allah or God. And there is really lack of concept about prevention. So the perception regarding diabetes was you have to walk. And if you're overweight, you can get diabetes. So they sought care when for other reasons, actually, not particularly for diabetes. They don't go to doctors or other people who they don't know because they trust the person who is known to the family. And they can go to pharmacy to check their blood sugar rather than do regular checkups. And because family support is available, a relative would take them to the hospital or doctor. Next, please. So what we did was emphasize on a healthy lifestyle, which meant 3 meals a day and 2 snacks in between, and exercise. There is in the rural areas still open spaces where people can go for walks, as opposed to the cities where the open spaces and parks are very quickly disappearing. So we told them about the body image, that is medium, not fat. And then what people consider as tension. So we said that tension is not a good thing for both males and females. Right, next please. So this is one of the testing centers, because we tested people for diabetes, and so people would gather at assigned place in the village, and then they would be tested for blood glucose, and measurements would be taken for anthropometry. Next, please. See, so this is a blood glucose test being done. What happened? Next. And then for oral glucose test, we are giving a drink of glucose, and this lady is drinking it, and then another sample is being taken. Next. And then anthropometric measurements, like the height is being measured, then waist is being measured, etc. Next. So we found that there was very limited knowledge and understanding of diabetes. And approximately, this is a huge number, approximately 1 in 3 adults in the rural areas are pre-diabetic or diabetic, and 3 in 4 are unaware of their status. So it's not a really nice situation. Despite the propaganda regarding diabetes carried out by BADAs, obviously it does not penetrate through to the rural areas. I would imagine the situation would be more or less the same in the cities. Because if you don't have a condition, you don't think it's going to affect you. So you live in a kind of a fool's paradise until you are hit by the condition. Next, please. So we applied the PLA cycle to diabetes, and in phase 1, as you know, we identify and prioritize problems. So people identified lack of exercise, then obesity, taking too much sugar as the problems, and then they plan strategies. So they emphasized on testing, on identifying diabetes in the community, and then put the strategies into practice. For example, women identified exercise as one of the strategies. So where would it be possible to do exercise for women without being stared at or without being criticized? That is what they did. So they identified places where they would walk together. So instead of just one person walking, they would go out in a group and walk. And then in the last phase, they evaluated and reflected on the progress. So we designed special manuals, and which was based on diabetes and its problems. Next, please. So you can probably see, I may have, I think I don't know, I must have thrown it, because the pictures tell you the symptoms of diabetes, like, going to the toilet too often, and what meal is good for you when you have diabetes, etc. So if you compare the PLA in MNH with diabetes, you can see that the age group we addressed in MNH were younger. So it was mainly women of reproductive age, women who were likely to get pregnant. And in diabetes, we aimed to to address older people. So it was more than 30. And in MNH, we focused on women, whereas in diabetes, we address both genders. MNH is a rather shorter span problem because it is limited to reproductive age, whereas diabetes is a chronic condition. And once you get it, at least type 2, you can get over it, but it is hard work. And in MNH, we address maternal and newborn issues such as hemorrhage, after postpartum hemorrhage, newborn infections, breastfeeding, etc. Whereas in diabetes, we address lifestyle issues such as exercise and diet. Next. So, what are the challenges in carrying out PLA? It's setting up groups. We found that men were available in the evening, and women considered evening as unsafe to walk around. So we had separate men's and women's groups. Now, the question of budget always comes up because nothing is for free. So if we want to scale this up, who will take the responsibility? Is it the government, the NGOs, and where would the budget come from? The other burning question is, can this be replicated in the urban setting? We know from Sneha's experience that they had in the beginning, they had issues carrying out the intervention in the urban slums because there was hardly any space available. So we'll have to think about this and do this in the urban setting as well. But I think for my main question is, who is going to scale this up? We have already shown that PLA is a very good way of reducing maternal and neonatal mortality, but nobody took that up from us. It's mainly, I think the other problem is that here no pharmaceuticals are involved because there's no medicine being sold. If we were selling medicine, if medicines were sold during this program, I'm sure pharmaceuticals would jump on the bandwagon and they would take up the challenge. We have to think about all this. Like, for example, SNL has now introduced chlorhexidine, selling chlorhexidine in the newborn packet. So perhaps something like that, safe delivery kit, for example. We can do something like that, and then get somebody on board. Thank you for listening. I hope this gives you some food for thought. Next, that's the end.
Thank you very much, Kishu.
Thank you.
That was great. Do you want to tip your computer down a little bit so that we can see your face?
Oh, okay.
Awesome. Much better. Yeah, no, it was a big learning curve for us, really, wasn't it? You brought up some interesting points about adapting the intervention so that men could participate as well as women, and we had to think about those gender norms about whether combined groups were good or separate groups. And I think yeah, bringing up the whole issue about sort of power and the kind of the motivation to scale up this type of intervention is quite interesting, and something that you need to find out before you do PLA. You know, is this something that people are going to be against because it's not promoting their particular material or their medicine. It's promoting something else. So interesting to bring in those issues of power there as well. So I think we're going to take some questions now. Let me see in the Q&A box. Okay. So Suchitra had a question for Annie. That means there are no prioritization exercise based on groups. So I guess Suchitra is asking about you know, the fast kind of doing all the phases in one meeting there. Perhaps you could expand on that, Annie.
Yeah, and of course it's a set of a cycle with a set of problems, and of course in the traditional cycle, within the first few meetings, the communities come together, they discuss the problems they face and prioritize those that are most important to them. And so this is something we definitely thought about as well in when making this adaptation. And in this pilot, the problems we included were really based on formative research and consultation with key stakeholders and the communities. And a list was developed. And currently, the groups do, of course, they do have that set of problems that hopefully really fit their own needs. But at the same time, within the cycle, at the end of each meeting, they vote on which problem they should discuss next. So there's a bit of a prioritization there. But in any kind of future project that uses this adaptation, again, that formative piece of research is really important, and the plan is there to really have always formal consultations with the communities themselves, so that they get a pool of problems that they can choose from, so that it reflects really their need within their community. So there's prioritization, but in an earlier stage as the project is being adapted to the local context.
Okay. Perhaps we can move on to Rachel's question. How can we make PLA to be more interesting? As most women's groups in our groups are complaining of discussing the same content and problems. That's a question from Rachel, who's from Maternity Worldwide Malawi. Kishu, how do you think we make our meetings interesting?
Right, am I unmuted? I honestly don't know. I think you have to add more topics. You know, like what are they addressing? Maternity worldwide, isn't it? So perhaps try to discuss how people, how women improve their condition in other situations. Like, you know, we had we used as what is the safe delivery kits. So perhaps, you know, from problems in the delivery and the pre-delivery situations, you can add a session on safe delivery kit, how to make it locally instead of forking out money to buy it. And so that would be another session. And I don't know about hemorrhage. I don't know how you can, perhaps, you know, just recognizing that bleeding is going to happen and you rush the person. Things like that. It's very difficult because it's again the same problems, isn't it? Which is claiming lives. So I think things like that, little things like that.
Yeah, I think
you
you're
must
right.
have some idea, Joe.
Well, that's what I was going to say. I was going to kind of throw it back to the community almost, and ask them what they want to know more about and what they would like to discuss. The other thing, I guess, is that the membership is, in my experience, usually quite constant across that kind of first cycle, but then it can sort of change thereafter. Annie, how do you make your groups interesting?
Well, I think it's just replying to what you just said there in terms of, you know, in the beginning, there's often a consistent membership, and then it can kind of change from there depending on the solutions that have kind of been identified. And I guess the interesting thing about the adaptation is that the groups will know which problem will be addressed next. And so that can kind of respond to the interest of a certain person. If they're very interested in that topic, they'll want to join the next meeting. If it's a topic that's maybe less of their concern because they're not yet pregnant, then they might not attend the next meeting. So that kind of adaptation might respond to dipping in and out based on your interest. And because it's a slightly shorter cycle, yeah, you don't have to wait until a certain moment before your the thing you're most interested will come up. So I think that might be an interesting element to really understand in this pilot project, if that's how people respond to the new kind of way of working through these problems.
Yeah, I think that sounds good. I know Mikey also responded in regards to sort of how we use kind of different tools within the meetings as well. So that's another way to kind of keep things interesting. Oh, sorry. The next question's from Himanshu. Excellent presentation, thank you. 2 quick questions. Participation by couples together rather than women and girls together. So I guess sort of what are the advantages, disadvantages of that, and why was the decision taken to not work with couples? So that's one question. The second question, can the Rotary be a partner? Can we help in a small target area? Absolutely. I think, you know, partnership working is absolutely what we'd like to do. So maybe you can take that first question, Annie.
Yeah, definitely. It is a really interesting question, and yeah, there's multiple ways, of course, of working within these settings, either with separate groups, as was done kind of in the diabetes trial, but also kind of jointly. In this particular pilot, of course, we recognize the important role that men play in SRH, and they're definitely encouraged to join. So even though I focus mostly on the women, definitely there's no they are still able to join the groups. And with this project, we're also really ensuring that we engage with community gatekeepers, and especially religious male leaders, to kind of orientate them on the importance of sexual and reproductive health, and really to gain their support for the PLA groups. And so the men are definitely engaged, but it would be very interesting to kind of think about joint groups of couples, but particularly in this project we were so focused on the unmarried women and adolescent girls that yeah, they're the main focus of this project.
Yeah, I think it's a very interesting point, and I think it's where the evidence is really quite less established. You know, what's the best way to work with men? I don't know so much about family planning, but maybe Kishu, you'd like to say about you know, kind of how the men and women worked separately together in our intervention about diabetes.
I mentioned that men wanted to work in the evening, wanted to take part in the PLA in the evening because they were free from their wherever they worked in the paddy field or wherever, and they could only attend in the evening. Now this couple theory we never addressed actually, and neither did the participants. And that can be quite relevant because then both could attend together. Whereas women would tell us that they don't feel safe in the evening. But if we had put it across to them that they could come with their husbands, perhaps, that would have worked. We must try this out.
Yeah, I think we were quite conscious about enabling the participation of women and men, and so yeah, that's why we ran those separate groups. But they did, when they had the community meetings, they came together. Of course, there were men and women there, and they could talk to each other about gender concerns. I know that women were concerned that their husbands didn't want them to cook less oily, less salty food, and then the husbands were complaining that that their wives were to blame for their diabetes, and so it was nice to have those two people from families in the same room to talk about that issue, and of course addressing gender norms around exercise that also happened in the community meetings as well. So.
There's a question for you.
Oh, but there's another question for you guys before that, so we'll do that one first. Are there any characteristics of health and social problems that are most appropriate for the PLA methodology? What do you think about that? Ishu, do you want to answer?
Would like to answer this question live, Mikey.
Sorry, I was just doing that in the background. Feel free to start. I'm happy to join in after you've given your response, Kishu.
Oh no, you go ahead. You go
okay,
ahead.
Yeah, I can kick off. It's a good question and something we get asked quite a lot. And in fact, most recently, our hardest job has actually been deciding where not to apply PLA rather than where to apply it. I think the core to this is finding those issues which you can coalesce a group around. So where there's enough people concerned about the issue in a community to meet together, to want to spend time, their valuable time discussing and trying to solve the problem. But also where community action will feasibly bring about an impact on that issue. And that's a broad range of issues. Clearly, community action can have an impact on quite a wide range of things. But there are other things that may be more structural, which require either additional interventions or a different kind of intervention to really have an impact there. I think the key for us is participation, is getting people into a group concerned about the issue, and then giving that group a problem that they can solve with the action they can take at the community level, whether that's alone or in collaboration with others. I think those are two considerations. And that means the pool is quite broad, but also helps to start identifying where maybe the edges of that arise, where are those issues we can't really have an impact on, maybe through PLA.
Yeah, I think that my kind of rule is to sort of you don't know unless you try, really, and kind of working out with people if it might be appropriate to the issue. I think is a good way forward. I don't know if you'd like to respond, Annie.
No, yeah, I think Mikey really highlights the most important considerations there that we would take in terms of adapting it to any other issue.
Okay, the next question is for me. Given your work on participation of people with disabilities in Nepal, do you think PLA would work for people with disabilities, and what kinds of issues might arise? Well, we did look at the attendance of disabled women in women's groups in Makwanpur, actually, and we found that they participated around about to the same extent as non-disabled women. which was really encouraging. And I think that that really speaks to kind of inclusion exclusion issues. I think that, you know, thinking about disabled women as members of the community, as mothers, and as grandmothers, and you know, mothers-in-law and so on. And I think that if you have a community where they are included as such, then there's no reason why they wouldn't come to the groups, really. I think that people with impairments, you know, there are access issues, you know, for different disability types, but and I feel like you know, community groups might not have the resources to be able to you know, provide provide Braille materials, for example, but it's really down to the facilitator and supporting the facilitator to identify and engage those people with disabilities in the group as members of community. You know, people may see them, and disabled people are often seen as people with nothing to offer, but of course they have things to offer. Of course they can address problems in their communities as everyone else can. And I think one thing which stuck with me from my research with disabled women was we spoke to one disabled woman who said, actually, my disability doesn't exclude me. It's the fact that I'm a widow that means I'm excluded. And that, you know, I think that doing an analysis of who is attending our groups and what are the factors affecting attendance is a really important piece of work to do, and we're trying to do that. We've just done a piece of work about the diabetes groups, actually, which we hope will be published soon, and we have done a little bit of analysis of the maternal and newborn health groups too. Yeah, that was a lot of talking from me, so let's go back to you panelists. Kishu, maybe you could talk about, answer Eric's question. Besides the unavailability of men during the day, are there any challenges that hinder men from participating in the meetings?
Oh, yes. Well, I mean, when we did the PLA cycle for MNH, we found that women didn't like men to attend all the meetings. The meetings which they thought would intrude on their privacy. So that was one of the factors which prevented men from attending the meetings. Whereas in diabetes, there was nothing. I mean, they were quite enthusiastic because diabetes affects both men and women. And men attended the meeting. You saw from the photographs, there were quite a few men. I think another thing will be if they are too lazy to attend meetings. I think that's it. You know, if they are interested in the subject, if the women want them, that's fine.
Yeah, I think that's an interesting point you made. I'm not sure I would think they were lazy, but it's that sort of whether it's within their domain of interest and their domain of control. Annie, maybe you want to say something about that.
Yeah, I think generally across all our projects, men do really become more engaged when it comes to the implementation of solutions, where they see they have an important role to kind of support women, whether they have access to certain materials to, for example, build a bicycle ambulance. Or so I think that's where generally we see male engagement really increase in the cycle, and probably because they have a feeling that they can contribute more to the discussion.
Yeah, it's something which I'm always kind of interested thinking about, sort of how to engage with those who have more power, whether it's men or mothers-in-law or who else. And often I think that the groups choose how they would like to engage with them, and they may not be in the most socially transformative ways, or they might be, but I think that's always been kind of my approach, is sort of be led by the groups themselves. I think there's one more question for me. In recent years, more focus on adolescent mental health. Do you think PLA could be adapted to help that issue? And if so, any ideas on how it would need to be adapted? I don't actually have any experience working on adolescent health with PLA, but I think there might be people in the audience from ECJUT who have that experience. As Mikey said, we're keen to draw on your experience too. I don't know if you'd like to.
Yeah, I can see Suchitra's online. She might want to join. Suchitra, I'm going to upgrade you to a panelist. You don't have to respond to the question if it's not an area of your expertise, but maybe you can give us an idea of what ECJUT's been doing in that issue.
If you don't want to talk, please let me know.
Hello? Yes. I'm on a Zoom meeting.
You're muted, Suchitra, if you'd
Hello.
like to say something.
Yeah, sorry,
So.
I just joined. I got disconnected because of this network connectivity. Could you please repeat? Or
we were just talking about the possibility of doing PLA for adolescent mental health. Do you have any experience on that issue?
Yeah. Yes, Joe. And before the meeting started, I also suggested about sharing PLA for gender-based violence, PLA for adolescent health, nutrition, and well-being, which includes adolescent health as well, and the mental health initiative. Actually, I'd also like to mention that like Annie, you were suggesting about you tried a different approach of PLA, like covering each problem, and they goes through all the phases in adolescent program also, because the problems were so vast. And with during the external consultations, the experts, they suggested that if you go with one PLA cycle, then there is a chance that you will the traditional PLA cycle, there is a chance that you will miss many of the problems. So we went for 4 mini cycles of education, then nutrition, then mental health and violence, and then health, because there are many NGOs working on health SRH issues. So these were the prioritization, and the groups only prioritized which problems to focus first, which theme to focus first, and then other cycles went. And while we were doing the meetings on mental health and violence, so the youth facilitators as well as the adolescents, there were few adolescents who were identified during the meetings, and fortunately we have few doctors who treated them, and through telepsychiatry also in counseling. And they also shared that we have our elder sister who is suffering from, we have our aunt who is suffering from, we have mothers who is suffering from this so how from this meeting it broadened, and now we have 100 such service users who are going through the process, like they are provided with low cost medicines, then telecounseling, and also follow up by the youth facilitators. They are trained. So maybe for the September 21st webinar, if it's not booked, we could share our insights. Even we could also have our youth facilitators who are directly engaged with the adolescents, to share their stories. How a school dropout, she dropped out because she was suffering from psychosocial disabilities, severe psychosocial disabilities, and how through the support group meetings and with support from the youth facilitators, she is now continuing her studies and also doing nutrition garden. So there are many new insights, and we have many things to share as well. And for the adolescent, this is one part of the 4 mini cycle, the mental health and violence. And and it's also the adolescent work is our city. It just got over, but we were very unfortunate because of the COVID hit, and we were able to collect only 46% of the data because the end line was going on when we had to stop, and all our primary indicators got affected. It was the dietary diversity, then anxiety and depression, mild and moderate, and as well as school attendance. So our team thought to stop it and not collect it, because we now also we are not sure, and schools are also not.
Yeah, no, I'm really sorry to hear that, Suchitra, but of course it's understandable. We've all been watching the horrific effect of COVID on India. I think that yeah, it sounds like it's really the topic for another seminar. That sounds super interesting. I think I'm just about to start a piece of work with Kelly Clark, which is about using sports in PLA. So so that will be very fun. That will be in Nepal. So hopefully I will be able to have, and that's all. That's addressing adolescent mental health specifically. So that will be exciting to share once we start. Yes, Sujitra?
Yeah, to add to this, apart, because working with adolescents, the transition phase, and to keep them engaged in the PLA meetings and discussion on health, nutrition and well-being. So they think it as all bhashan baji or speeches, lectures. So to keep them engaged, the leadership activities which involve sports tournament and all of these insights came from the formative research. Like 1 year was completely dedicated for doing the formative research through quantitative surveys of around 3,324 girls, and qualitative surveys with adolescents, with youths, with their parents, with their family members, try to design the intervention which is for the adolescent, designed by the adolescent. So we have many learnings and many insights, and how the leadership activities, like involving them in sports tournament, in hill treks, how the early marriages reduced. Yeah.
Can I just jump in? Thanks, Suchitra, for jumping in and responding to a question without being prepped. So thank you for that. And just to say, the idea for a future webinar, particularly involving adolescent champions, sounds fantastic. So something we'll definitely reach out about. I think that the community would love to hear more. And I think it would be a great way to get some of the beneficiaries and some people actually doing the PLA on the ground to speak directly to us. And just to mention that Rachel Kalima from Maternity Worldwide in the chat mentioned they also tried a mental health PLA pilot over 6 months in Malawi, and they turned out to be massive. They realized that more women were suffering from mental health issues than they ever imagined. So clearly resonates with what you found as well. So clearly an area for future work around PLA.
Also, just to direct people to the research that Suchitra and colleagues did around looking at maternal mental health. They've published a nice paper on that, which I'm sure is in the library, and the effect of PLA on that. There's one more question for Keshu. Don't you think adapting the concept of male champions in MNH groups in Nepal might help to enroll more men in MNH groups? So perhaps Rachel meant Bangladesh. What do you think about that? Adapting male champions for maternal health issue.
What are male champions?
Well, I think that male champions would basically be sort of almost like group leaders to champion the issue of maternal health. So to try and address community barriers to maternal health. What do you think about having sort of male leadership in a maternal health intervention?
I think we need to have some focus group discussions on this, because there are some subjects in maternal neonatal health which women don't want to share with men because they consider them to be too sensitive. That's why we didn't have male and women group attending the same meeting, because they didn't want to discuss it in front of men. Apart from that, I suppose male champions could increase the attendance of men. That would be good. But at the moment, we are not working on maternal and neonatal health and PLA.
Annie, did you have anything?
Sorry?
Yeah, but we'd like to, I'm sure. I'm sure we'd like to keep working in maternal
exactly.
health. It's not like all the problems have been solved. Maybe, Annie, would you like to that question as well?
Down.
Sorry, Kishu?
No, our neonatal mortality has come down to 19, and I think you have to be more than 31 for groups to be to have an effect.
Okay.
No, I think it's definitely an area that we would love to do more research in. So also, if anyone in the community of practice does have more experience with kind of engaging men and as well as kind of male champions, then we'd certainly like to hear more about that. And I think it could be another interesting topic of discussion often, these are questions that come out from the community. So I'd love to kind of hear more from people who might have had experience in that.
But for diabetes, I think that would also be very important to get male champions to, to say that we need to address the question of diabetes.
Yeah, it's an interesting thing to consider, how to maximize participation, but also maximize kind of conversations that need to happen for social change. So I think we're out of time. So maybe I'd like to end by thanking very much Annie and Kishu for your excellent presentations, and thank you all for the discussion and the really interesting questions. Please,
Thank you as well,
please be in touch if you have ideas for future seminars. Mike, is there any ending announcements you want to make?
No, just to mention, thanks for everyone, the panelists, yourself, Joe, for moderating, and everyone for attending. We had a good attendance of almost up to 30 people at some points, and just over 30 at one point. Just to mention, this webinar will be is being recorded, so we'll put it online, so it's available if people want to watch it afterwards or to share it with others. Look out for the monthly newsletter, which will guide you on what's happening in the next webinars and other things coming up. But also already got a few good ideas from what people have mentioned for future webinars. So yeah, thank you all.
Nice to see you all. Bye-bye.
Thank you. Bye.
Bye.
Cheers.